So I'm a board-certified psychiatrist, and I've helped over 160 PMHNPs get clinical confidence in their diagnosis skills, treatment skills, and being able to get excellent results for real-life patients. So today we're going to be covering Olanzapine, Zyprexa. So you'll know how to use this medication, how to have patients get the most out of it, its mechanism of action, its dosing, its side effects, special considerations to know about, and how I personally use it as a psychiatrist in clinical practice. So with Zyprexa, the first thing we got to know is its mechanism of action. And so with Zyprexa, it is a potent D2 blocker, so D2 antagonist. And so this is really important because this is what gives us the antipsychotic benefit. Zyprexa is one of the ones that I consider when I need to hit psychosis hard, or I need to get someone out of mania like quick. And so it's a very potent D2 agonist. But it's also got some other activities too, and that's why it's used in other uses as well. So it also has 5-HT2A blockade antagonism. And so this is really helpful because this is what gives us mood benefits. Zyprexa is often used for mood stabilization too. So we use it for bipolar, used for treatment-resistant depression, used for agitation. And so a lot of those reasons is because of the 5-HT2A antagonism that helps increase the serotonin activity for the patient. But other than that, it's got a couple other receptors. Blocking the histamine receptor, this causes a weight gain, and the sedation we can use to our benefit if we dose it at night, so that way we can help patients get better sleep as a side benefit. Though the weight gain is definitely a problem with this one. There also is orthostatic hypotension that can happen, and that's from the alpha-1 antagonism. So alpha-1 constricts the blood vessels, so if you block it, then the vessels get dilated, and this will cause a decreased blood pressure. So specifically, the orthostatic is the most common iteration of this, where the patient will go from lying down to sitting to standing, and they'll have a drop in blood pressure. So for example, I had a patient at the VA, they were like, yeah, I get dizzy whenever I wake up getting out of bed. And it was from the Zyprexa that they were taking at night. I reduced the dose, and they were still getting good benefit, but the orthostatic hypotension went away. It also has some muscarinic activity as well. This can cause anticholinergic effects. And so what that means is this is what's going to cause the side effects of dry mouth and constipation, sometimes some cognitive confusion, that type of thing. The main things that it's used for, so schizophrenia. This is a very common choice for schizophrenia. Like when I was in residency, a lot of our attendings would use this inpatient a lot to treat schizophrenia. For bipolar, particularly bipolar mania, as well as some depression as well, but particularly the mania. And the reason it's used a lot for mania is because, I mean, it's got the mood stabilizing benefits, but as an antipsychotic, it like really hits hard. So it's able to really, and the sedation too. So it's able to help patients go to sleep, and it's able to target a lot of the mood lability and the thought disorder component that tends to occur with mania. It's also used in treatment-resistant depression as well. I mentioned bipolar depression, but also in treatment-resistant depression, it's used as an adjunct. You can also use it off-label for things like BPD, for a lot of the agitation, just agitation in general, actually. I do some moonlighting in the prison system, and in the prison system, it's particularly used, Zyprexa is. I mean, one, because it's cheap, but two, because a lot of those patients tend to be very agitated, aggressive, so it's used for that as scheduled. So very common use in that it has. Some side benefits is that it's also used for eating disorders, particularly anorexia. Because of the weight gain benefit, it can help disrupt some of the thought disorders too. So usually it's used in anorexia to help with a weight gain and appetite increase. That's a common use for that. To dose olanzapine, typically its dosage ranges from 2.5 milligrams to 20. So on the lower end is when you might be treating some of the depression stuff. You wouldn't really use this for sedation, but maybe agitation, you might use 5. And then as you get to the higher end, that's when you start using it for schizophrenia, right? So at the end of it, we have schizophrenia, maybe severe agitation or severe aggression. And then on the lower end, maybe some mood benefits. And the dosage is not as delineated as it is for Seroquel, so it tends to be a range. You'll start at 2.5 to 5 here, and then go up to 20 here. Sometimes that's the FDA max, but the FDA max does not mean that you have to stick with 20. You can actually go higher if the patient requires it. Typically, the max dose I've seen used is about 30 milligrams. I've seen this in the prison system, as well as severe treatment-resistant cases. One of the unique things about olanzapine, Zyprexa, is that it is considered the second best antipsychotic. So they did this trial called the CATIE trial. And so pretty much what that is that it's comparing different antipsychotic efficacies. And so in that one, clozapine was considered number one, but olanzapine which is a close cousin to clozapine, was the second one. So I consider this like a heavy hitter, really good antipsychotic. It also comes in an LAI form. So this dosing oral, but there's an IM form typically used for agitation, usually 5 milligrams. There's an ODT form, oral dissolving. This I would use for agitation, right? Because the oral dissolving one will hit quicker than the PO one will. So if you have an agitated patient who is willing to take oral meds, then the ODT can be preferable because they'll have a quicker response. There's also an LAI, long-acting injectable. But the thing with the LAI is that it has a risk of delirium afterward. Like you have to monitor the patients for fewer hours. So that's why no one really uses it. I've never seen the LAI used once. Yeah, it tends to be pretty well absorbed, which is the nice part about it, about 60. Another thing we got to note is that because it's very potent, potency refers to how strong it is, like how little of a dose it takes to have a good antipsychotic effect. So it's potent. And so because it's potent, it binds D2 tightly. And so because it binds the D2 receptor tightly, sometimes you can overshoot it. And so if you overshoot it, that can lead to increased EPS side effects. So that's the downside. Typically, when we're trying to do antipsychotic binding, we'll try to get like 60 to 70% of binding. That's the sweet spot. And so if it binds too tightly, it's really easy to overshoot it. And that's why oftentimes just overloading an antipsychotic more is not going to help you get any faster psychosis remission, because you've already kind of bound that sweet spot that you need for the activity. I mean, other side effects, while we're going into side effects, are we talked about the EPS risk, but also the weight gain. So that's the biggest thing with olanzapine. So think of olanzapine like obese. It's by far the worst for weight gain, sedation, decreased blood pressure. So all those things that we mentioned. So, I mean, with weight gain comes the A1C, the lipids, all those can increase as well too. It increases both appetite as well as decreases metabolism. So that is a big trade-off of this medication. And we also mentioned the anticholinergic side effects from the muscarinic antagonism. Dry mouth, sedation, constipation. Not the sedation as much. Sedation is more associated with the H1, but definitely the constipation. So this is something you have to be careful with clozapine as well as olanzapine. For example, I remember hearing a story. This was on clozapine, but the patient was on clozapine and they were complaining of bowel pain, but got dismissed. It turns out the patient got worse and worse until they started getting septic. They had so much constipation that they had a small bowel obstruction and it ruptured. Those are the main side effects. It's the main side effect of that. So the dosing of it, this is also typically given QHS at bedtime because of the sedation, and it's given QD. Because its half-life is 30 hours, you only need to dose it once a day. You don't need to do BID dosing or whatever, which is nice. And so the LAI we'll talk about in a different video as well. And luckily, Zyprexa is pretty cheap, so it comes in, doses, so it comes in 2.5, 5, 10, actually 7.5 as well, and then 20. So you have a big dosage range that you can work with, at least for the oral. So those are the main things that you need to understand about Zyprexa. It hits hard, very potent. It's a great choice, especially if you're treating psychosis or bipolar. You can use it for depression, but it's much better as an antipsychotic agent for psychosis than it is for depression. But it is used. It is definitely used. And yeah, main side effect is the weight gain, the sedation. Those are the things to be worried about. So you may not want to use it as a first choice for someone who is already obese. You may want to use a lower metabolically active agent. So I hope that's helpful. If you're a PMHNP and you really want to learn psychiatry more from me, more in depth, you want to gain clinical confidence with patients, you want to really be able to treat patients without imposter syndrome, you want to get recognized for clinical expertise, you feel like you don't get enough support or mentorship, I have a PMHNP community where I teach all this stuff in detail and including a weekly Q&A call where you get to ask me directly your questions. And we've had over 160 members join so far. Yeah, it's been very valuable to them. Otherwise, I will see you in the next video.